Okay, go ahead.
Thank you, Rachel, for the introduction and the invitation to present for Project ECHO. I have no conflicts to declare, and all the information discussed in today's presentation is based on my own clinical experience. Throughout the talk today, I will refer to non-invasive prenatal screening as NIPS, sometimes referred to as non-invasive prenatal testing or NIPT. They are the same. I will be discussing NIPS technology and its utility in two different parts. So today's part is going to focus on NIPS as a screening tool for common chromosome abnormalities. So first, why do we offer screening for chromosome abnormalities in a pregnancy? We know all pregnancies have a background risk of about 3% for congenital anomalies, the vast majority of those being multifactorial, teratogenic, or unknown. Of the genetic causes for birth defects, about 10% of those will be due to a single gene disorder, and another 15% due to a chromosome abnormality. This is an image of a karyotype, which can only be generated from a tissue or a blood sample, such as that from a prenatal or a postnatal diagnosis. So this is just a reminder that we are not able to get a karyotype from an NIPS. Highlighted here are chromosomes 21, 13, and 18, which have been interrogated with various screening methodologies, such as the first trimester screen, a quad screen, sequential screen, and so forth. When in excess, these common trisomies are ones that are most likely to be viable and to continue in a pregnancy, whereas other chromosome abnormalities often result in early pregnancy loss. The sex chromosomes have not historically been analyzed through traditional screening methods until the development of NIPS technology. In 1997 is when Lowe and his team discovered that cell-free fetal DNA is present in maternal circulation. So cell-free DNA are fragments of DNA. These are released from the nucleus of cells as they undergo cell death or apoptosis. About 10 years after that, his team identified extra chromosome 21 that was present in the sample, and it was also reflective of a fetus with trisomy 21. That same year, they confirmed that the cell-free DNA of interest that they were looking at was actually of placental origin. NIPS then became available in the US in 2011 and is now available internationally, and the cost significantly lower today than it was when it was first available. It's now covered by most commercial insurance companies for the average risk patient. Medicaid is accepted by almost all laboratories that do perform this screening test, and financial assistance is available and often generous. So I work with a population of patients who are uninsured, and I am able to offer this testing to them with the assurance that they can qualify for these financial aid programs. These programs usually take into account, number of individuals in their household, what their monthly income is, and based on a sliding scale, the cost of the test does get reduced, and it often is zero. So the NIPS really fits the bill for an ideal screening test in that it has a high sensitivity and specificity, it has a low false positive rate, and it has the ability to be performed early, as early as 9 to 10 weeks of gestation. It's also the only screening tool for fetal sex aneuploidies or fetal sex chromosome abnormalities. As a reminder, NIPS is not diagnostic, because it is analyzing placental fragments of DNA and not fetal fragments. Therefore, any positive results should be confirmed with a prenatal or a postnatal diagnosis. Based on the performance of NIPS, the consensus among ACOG, the International Society for Prenatal Diagnosis, and the American College of Genomics and Genetics is that NIPS be offered to all women, regardless of their chromosome abnormality risk. Next slide, thank you. You will see offerings if you're filling out a requisition form for an NIPS, for example, you might see offerings for things such as microdeletions. That might be a 22q microdeletion or Prader-Willi, Angelman, Williams syndrome. There are others. But utilizing NIPS for screening of microdeletions is really not recommended because test performance is really difficult to estimate. And that's partly because the prevalence of these conditions is really variable and not well known. So if you do have a patient who is motivated to understand all possible information about their pregnancy, or say they do have a family history of one of these microdeletions, NIPS technology might not be the best option, and really performing some type of prenatal diagnosis with a microarray analysis would provide the most comprehensive information. So a little bit on the technology of NIPS, it can be divided into two methodologies, and each of those methodologies have their own benefits and limitations. So the figure on the screen is demonstrating a basic principle of a process used in genetic testing called massively parallel sequencing. And a simplified explanation of this would be you're taking the DNA of interest, you're labeling it, and then you're building a sequence library based on those labels, and you're ordering it. And that's usually being ordered based on a control. So for cell-free DNA, that sequence library that gets built is then mapped to the specific chromosomes that that control matches up to. And those chromosomes are counted. So because the fetal DNA and maternal DNA, they have different methylation patterns, it's possible that we can determine the maternal contribution as well as the fetal contribution. And if you were to look in the bottom right row, you can see that there is a discrepancy in the fetal contribution for chromosome 21, where they would expect there to be a 90% maternal and 10% fetal contribution. It's actually an 89% maternal and 11% fetal. You might think, wow, that's really small, but in the grand scheme of finding the tiniest little pieces of cell-free fetal DNA within a maternal blood sample, that 1% does make quite a difference. So this result would actually report as high risk for trisomy 21. The counting method is the most common platform used, and a benefit of this particular technology is that it does require a lower fetal fraction for analysis. The other methodology is a single nucleotide polymorphism methodology, or a SNP. You can think of a SNP as just a common variation between humans. So it's just genetic variation. There's a difference in every 1 in 1,000 nucleotides. So basically what makes us all different from one another, but we can use these SNPs to compare the fetal and the maternal cell-free DNA, and we can come up with a fetal genotype. And using that genotype, we can screen for common trisomies, the sex chromosome abnormalities. This particular technology can also screen for triploidy, which is when a pregnancy has 69 chromosomes instead of the expected 46. And it can also determine zygosity in a twin pregnancy. This analysis does require a higher fetal fraction than the counting method. And Natera's Panorama screen uses SNP-based technology, while all other NIPSs that are commercially available are using the counting method. Both of these technologies require or depend upon the amount of fetal fraction within the sample. So you can think of the fetal fraction as the fetal component of the DNA that's coming from the maternal circulation. So again, those cell-free DNA fragments are just DNA being released from the nucleus of cells as those cells undergo just regular programmed cell death, like all of our cells do. So when that occurs, you're going to get two different types of cell-free DNA. You're going to get the fetal portion, which we know is coming from the placenta, or specifically the placental trophoblast. And then you're going to have a maternal portion, and that is coming from the adipocytes, or the fat cells, as well as some white blood cells. So we can calculate that fetal fraction by taking that placental trophoblast and just dividing it by the total cell-free fetal DNA in the sample. Studies have consistently shown that fetal fraction tends to average around 10 to 15% in the first trimester and early second trimester. And fetal fraction is lower in earlier gestation due to placental size. So as the pregnancy continues, the fetal fraction does increase by about 0.1% between 13 and 20 weeks, and then it ramps up a bit at about 1% increase after that. The minimum fetal fraction threshold to perform an NIPS analysis varies depending on the methodology, but is typically between 2% and 4%, with that SNP-based technology being on the higher end of the 4%. A low fetal fraction can result in a no-call result. So some of you are probably familiar with these results where you get your patient's result back and it says low fetal fraction. And essentially no analysis has been performed. They weren't able to because there wasn't enough of that cell-free fetal DNA sample. And there are several factors that can affect this fetal fraction. Gestational age and maternal BMI are probably the most common. Gestational age has a linear relationship. So as gestational age increases, so should fetal fraction. And then maternal BMI has that inverse relationship. So studies have shown that in patients with a high BMI, they have increased apoptosis in their adipose cells. So that's going to increase levels of the maternal contribution, which then dilutes the fetal contribution and results in that decreased fetal fraction. Other factors that we know can affect fetal fraction include the size of the placenta. Recent studies have shown an association between low fetal fraction and placental dysfunction, including preeclampsia, fetal growth restriction. Maternal factors also play a role. This can include carrier status. So women who have a hemoglobinopathy, such as sickle cell disease or beta thalassemia, they are more likely to have a lower fetal fraction and higher no-call rate. Speculated that the maternal cells are undergoing apoptosis at a higher rate, which again dilutes the fetal fraction. We also know that certain medications, specifically low molecular weight heparin or Lovenox, tends to have lower fetal fractions and higher no-call rates. And that's because there is a reduction in the amount of cell turnover from the placenta. Fetal fraction has also been consistently shown to be lower in pregnancies who are affected with an aneuploidy, as well as in multiple gestations. So testing technologies each have their own benefits and limitations, and selection of the NIPS technology really depends upon the clinical scenario. A general rule of thumb is that pretty much any patient sample could be sent to a lab that uses the counting method. There really aren't many contraindications other than a high order multiple pregnancy, like a triplet or beyond. But if we are sending to a SNP-based lab, then there are some contraindications and some things to consider, one of which is the patient's weight. So I arbitrarily use the number of 250 pounds because in my anecdotal experience, that's what I found to be getting into that realm of a low fetal fraction. So if I have a patient that's over that 250 pound mark, I typically am going to send to a lab that uses a counting method and not a SNP-based lab, because the counting method has a lower fetal fraction threshold. Also, if we have a patient that is consanguineous, so the SNP-based method, because it is genotyping, it can identify what we call runs of homozygosity. And that means that it can tell that there's a match or a heavy match between the fetus and the mother, suggesting that there is a consanguineous relationship between the parents. So in those cases, again, a counting method is the more appropriate option. There are also cases where NIPS is just not the appropriate screening tool. So if the mother has a chromosomal rearrangement, like a translocation or an inversion, false positive results may occur, especially if she is carrying, say, an unbalanced translocation where she might have extra chromosome material. You might get a false positive result because it's really picking up maternal chromosomes rather than fetal. Also, if you have a family history of recurrent pregnancy loss, which could suggest one of the parents are carriers of a translocation, NIPS is likely not the most helpful tool. They really should be undergoing some type of prenatal diagnosis. When ordering an NIPS on a pregnancy with a vanished twin, I always would use caution there. So SNP-based laboratories, they just won't accept a sample where there's been a vanished twin, but you can still send that to a counting method lab. However, there is always that risk that the testing is being performed on residual placental DNA from the demised twin. So anecdotal evidence suggests waiting anywhere between 6 and 12 weeks after the vanished twin to reduce that chance for a false positive result. In talking to your patient about NIPS, it's important to disclose the possibility of 3 types of results rather than just the positive and just the negative. So really should be explaining that, you have a low risk result or a negative result, high risk or positive, and then there is a third category, which is the uninformative result. Important to remind them that this is not diagnostic, and any positive result is recommended to be tested with some sort of diagnostic follow-up, whether that is prenatal or postnatal. You probably don't have to mention the thing about fetal sex, because in my experience, as I'm sure in many of yours, most patients already know about this, and they're wanting to have the test usually just because it can tell us this. But I always encourage them that doing this test has medical implications, and to make sure that they are aware of that. But it does allow for fetal sex prediction, and that is based on the presence or absence of the Y chromosome. When returning results to your patients, there are several concepts to keep in mind, as well as to highlight, reminding them that the screening is limited in scope. So while a negative result is certainly reassuring, it is not diagnostic of a normal fetus. Anytime we have a positive result, we should really be discussing that result in terms of a positive predictive value, or a PPV. And anyone receiving an NIPS should also be offered a maternal serum AFP only screen to screen for neural tube defects. All results should be interpreted in the context of the clinical findings. So for example, if you have an NIPS that's negative, but your patient has multiple abnormalities seen on ultrasound, the next step is really to be offering a prenatal diagnosis for microarray or karyotype, or even molecular analysis if you're suspicious for a single gene disorder. And anytime we do have these high risk results from NIPS, they can really be representative of a few different things. One, the mom herself could be mosaic or have a sex chromosome abnormality. The result might be representative of confined placental mosaicism, and the fetus can be normal. The result might represent fetal mosaicism, in which case there would not be a full trisomy, and that can change things in terms of outcomes and prognosis. Or in the case of a vanished twin, the result may represent the non-viable conception rather than the viable fetus. So in order to discern any of these possibilities, prenatal diagnosis is really recommended. And in some cases, we're also offering blood chromosome analysis to the mother if we suspect that she might have a chromosomal difference. Some language that you can use when returning a low risk or negative result to your patients, telling them that low risk greatly reduces their chances for these chromosome conditions, but does not eliminate them, and that the screening test is only evaluating 5 chromosomes, and that we have 23 of them, so 18 other chromosomes were not included, and if they are interested in that information, prenatal diagnosis remains an option. I find that patients feel very reassured by this information and generally don't request a prenatal diagnosis at this point. But I do get the question, so this means everything's okay with my baby. And of course, offering reassurance that yes, at this point, these conditions, the chance for any of these in your pregnancy is very unlikely. But reminding them they will have an anatomy scan, and if there is anything of concern at that point, prenatal diagnosis remains an available option. Some language for disclosing a positive result, telling them that their NIPS has an increased risk for trisomy 21, but that this is not a diagnosis, and that the chance the baby is truly affected is whatever that calculated PPV is. The only way, of course, to be sure is through some type of diagnostic test, whether that's prenatal or after birth. and then those available options based on gestational age, and a referral for genetics consultation, for maternal fetal medicine, and a targeted ultrasound. Any positive result is truly a concerning result, because the screening test is identifying extra chromosome material. And that's an important part to remember. The thing is, we just don't always know where that material is coming from. So whether it's coming from the fetus, the placenta, or the mother. So for those high risk or positive results, we want a positive predictive value to be provided to patients, and that helps them understand the chance that their fetus or their pregnancy is truly affected. This value is different from sensitivity of the test because it's taking into account the prevalence of the condition in the population, and it's also basing it on the maternal age. So it's more of a personalized risk assessment. In this example, we are determining the positive predictive value for a screen positive Down syndrome, and we're using the maternal age as the a priori risk, with an incidence rate of 1 in 700 for Down syndrome in our population. So you can appreciate here how the positive predictive value increases with increasing maternal age. For someone who is 23 years old with a screen positive NIPS for Down syndrome, the chance that their fetus is truly affected is about 50%. But if you have this exact same test result in a mother who is 43 years old, that positive predictive value is now 97%. So you can see that this particular value can be really powerful in helping patients decide whether they do want a diagnostic test. And ACMG actually recommends that an NIPS result, that the report itself should have a positive predictive value listed on there. Not all labs are following suit with this, so I would encourage each of you to become familiar with a published positive predictive value calculator as the one I have listed here. It's pretty simple to use. You're just plugging in mom's age and the particular condition that she screened positive for, and it calculates what that PPV would be for your patient. So we discussed the high risk and the low risk results. The third type of result is the uninformative result. The uninformative result, or the no-call result, largely falls into two categories. The first category is that low fetal fraction. Some labs will suggest a redraw for the first failed attempt, but you should use your clinical judgment as to whether a redraw is appropriate. So for example, if your patient has a high BMI, then a redraw likely is appropriate, and you might even consider waiting a couple of weeks to allow time for that fetal fraction to increase. In circumstances where there are 2 failed NIPSs in a high BMI patient, prenatal diagnosis should be considered. If the patient does not have a high BMI and has a low fetal fraction, and if the patient doesn't have any maternal conditions, she isn't taking Lovenox, and especially if she is at advanced maternal age, then offering prenatal diagnosis as the next step should be considered, and a redraw is really probably not very appropriate in this setting. We know that low fetal fractions do have an association with fetal aneuploidy. The second type of uninformative result is the atypical finding. This is a confusing result, because on the report you'll say that trisomy 13 and trisomy 18 are low risk or negative, and maybe next to one of the sex chromosomes it might say atypical finding, not able to report. In this circumstance, this result is highly suspicious for an abnormality involving either the fetus, the mother, or both. So calling the laboratory is always my next step when I get these results. I want to see what that raw data, the background data tells us. And the labs do have genetic counselors on call to answer these questions. And they can actually tell you what background information, if it was one of the sex chromosomes, or even something outside of that. And that way you can point your patient in the right direction. Referral to genetic counseling or maternal fetal medicine, or both, is always recommended for an atypical finding and should be considered for any low fetal fraction, especially in the absence of a maternal condition or high BMI. So to wrap up the didactic portion, if we have a high-risk trisomy 13, and if ultrasound shows corroborating evidence, such as a holoprosencephaly or a cleft lip, do we still need to pursue diagnostic testing? Next slide, please. And the answer is yes. So confirming a diagnosis is important for determining the cytogenetic nature of the test result. So remember, NIPS is only identifying the presence of additional chromosome material, but it's not telling us where or even how much is present. So a karyotype can help us differentiate between a rearrangement, such as a translocation or inversion, a true trisomy, or even a deletion or duplication or mosaicism. So if the pregnancy were to be affected with a rearrangement or copy number variant, we'd then want to do parental testing. And if the parent's a carrier, then we know the risk of recurrence in a subsequent pregnancy is much higher than just a regular trisomy. And this would also inform other family members' risks. And that does conclude the didactic portion of my talk. I'm happy to answer any